In this lecture, we will start discussing the drugs that affect functions of our nervous system, and in its first part, we will focus mainly on those agents which affect cholinergic neurotransmission of efferent innervation. So, our nervous system is divided into two anatomical divisions: the central nervous system, CNS, which is composed of the brain and spinal cord, and the peripheral nervous system, which includes neurons located outside of the brain and spinal cord. The peripheral nervous system is subdivided further into the efferent and efferent innervations, or divisions. The efferent neurons carry signals away from the brain and spinal cord to the peripheral tissues, and the efferent neurons bring information from the periphery to the CNS. Efferent neurons provide sensory input to modulate the functions of the efferent divisions through reflex arcs or neuronal pathways that mediate a reflex action. The efferent portion of the peripheral nervous system is further divided into two major functional subdivisions, which are somatic and autonomic nervous systems. Autonomic nervous system regulates the everyday requirements of our vital bodily functions without the conscious participation of the mind. Because of the involuntary nature of autonomic nervous system as well as its functions, it is also known as the visceral, vegetative, or involuntary nervous system. It is composed of the efferent neurons that innervate visceral smooth muscles, cardiac muscle, exocrine glands, thereby controlling digestion, cardiac output, blood flow, and ganglion secretions. This part of efferent innervation is further subdivided into two major parts, which are called parasympathetic innervation and sympathetic innervation. The somatic efferent neurons, conversely, are involved in the voluntary control of functions such as contraction of skeletal muscles essential for locomotion. The main targets for the pharmacological agents that act on the efferent innervation may include different types of receptors which are located both in the synapses and extrasynaptical spaces. Also, enzymes which regulate the concentration of mediators in the synaptic cleft, and systems of mediators transport. In this lecture, we will mainly discuss the drugs and the targets for such drugs that regulate neurotransmission of cholinergic synapses. Before we start to talk about the drugs, a few words about the physiology of cholinergic neurotransmission. As it's known, the main neurotransmitter in such synapses is called acetylcholine. It is produced from acetyl coenzyme A and choline molecules using the enzyme choline acetylase. Later produced acetylcholine is accumulated in specific particles which are called vesicles, and the membrane of these vesicles protects acetylcholine from its degradation in the presynaptic nerve endings. When a nerve impulse comes to such ending, it results to the depolarization of cell membrane, opening of voltage-gated calcium channels, influx of calcium ions, and consequently it leads to the fusion of the membrane of such vesicles with presynaptic membrane of this nerve ending. And it results to the release of acetylcholine from the vesicles into the synaptic cleft, which later leads to the diffusion of neurotransmitter from the membrane. When acetylcholine reaches the postsynaptic membrane, it interacts with corresponding cholinergic receptors on the surface of this membrane. Such interaction triggers the development of some kind of response, in postsynaptic membrane, and depending on the type of cholinergic receptors that are located there, we may have different types of responses. For example, depolarization of postsynaptic membrane and excitation of the effector cell. The duration of time during which acetylcholine can interact with postsynaptic receptors is limited because this neurotransmitter can be quickly destroyed, hydrolyzed, due to the activity of enzyme cholinesterase or acetylcholinesterase. So normally acetylcholine acts only during several milliseconds, and after that it is decomposed into choline and acetic acid. Later, the major part of acetic acid and almost half of choline are diffused from the synaptic cleft to the blood vessels, and they are removed from this synaptic cleft. And approximately one half of choline is reuptaken back to the presynaptic nerve ending, where it is utilized for further production of acetylcholine, and this process repeats. Two families of cholinereceptors, designated muscarinic and nicotinic receptors, can be distinguished from each other on the basis of their different affinities for the agents that mimic the action of acetylcholine. M-cholinereceptors, or muscarinic receptors, belong to the class of G-protein coupled receptors, so-called metabotropic receptors. These receptors, in addition to binding acetylcholine, also recognize muscarine, an alkaloid in certain poisonous mushrooms. By contrast, the muscarinic receptors show only a weak affinity for nicotine, alkaloid found in tobacco and other plants. There are 5 subclasses of muscarinic receptors. However, only M1, M2, and M3 receptors have been functionally characterized. M1 cholinergic receptors are mainly found in different parts of CNS, as well as in vegetative ganglions and in gastric parietal cells. M2 receptors are widely found on cardiac cells and smooth muscle cells. M3 cholinergic receptors are found on the bladder, exocrine glands, and smooth muscles. The second type of cholinereceptors are called N-cholinereceptors. These receptors, in addition to binding acetylcholine, also recognize nicotine, but show only a weak affinity for muscarine. The nicotinic receptor is composed of 5 subunits, and it functions as ligand-gated ion channel. Binding of 2 acetylcholine molecules elicits a conformational change that allows the entry of sodium ions, resulting in the depolarization of the effector cell. Nicotinic receptors are located in the CNS, in adrenal medulla, autonomic ganglia, and the neuromuscular junctions in skeletal muscles. Those receptors at the neuromuscular junctions are sometimes called as NM receptors, and the others are called as NN receptors. If we look at the structure of autonomic or vegetative nervous system, we can find that it consists of 2 major parts, which are sympathetic and parasympathetic branches. Both of these parts consist of 2 neurons and 2 fibers. The first neuron of both sympathetic and parasympathetic branches is located in the different parts of the CNS, in the brainstem or in spinal cord. And this neuron starts a fiber, which is called preganglionic fiber, which ends at the ganglions, sympathetic and parasympathetic ganglions. The difference between them is the following. Usually, sympathetic ganglions are located close to the spinal cord. That's why preganglionic fiber is quite short as compared to postganglionic fiber in sympathetic branch. Parasympathetic ganglions are located inside or close to the effector organs. That's why Preganglionic fibers are usually longer as compared to postganglionic fibers. Receptors that are responsible for the neurotransmission between pre- and postganglionic fibers are always N-cholinergic receptors or nicotine-sensitive receptors. They are located on the surface of neurons in the ganglions. Effector organs, they contain different types of receptors in sympathetic and parasympathetic branches. If we are talking about parasympathetic system, there we can find M-cholinergic receptors that are located on the cells of these organs. In sympathetic branch, we have different types of adrenergic receptors, alpha and beta adrenergic receptors, and as a result, neurotransmitter that is responsible for activation of this receptor is noradrenaline or norepinephrine, as opposed to the parasympathetic system where acetylcholine plays a crucial role in this process. When we are talking about the localization and the major effects of excitation of M-cholinergic receptors, we should note the following. First of all, the neurons of the central nervous system. Muscarinic receptors are widely distributed in the different regions of the brain and spinal cord and perform a variety of different functions. They can be found in the brain cortex, in reticular formation, limbic system, stereopallidal system, in the centers of the nervus vagus, in vestibular analyzer, and so on. And in more details, we will talk about the effects of these receptors activation when we talk about pharmacology of CNS. The second localization of M receptors is smooth muscles of blood vessels in different parts of the body, such as skeletal muscles or in pelvic organs. Stimulation of M receptors there produces mild to moderate vasodilation. We should note that in majority of cases, the tonus of blood vessels is regulated by sympathetic influences, and parasympathetic nerves through stimulation of M receptors play a secondary role in this process. The next is the group of the effects which depend on the stimulation of muscarinic receptors in the eye. First is the contraction of the circular muscle of the iris. Muscarinic receptors are widely found in this muscle, and their stimulation results in the contraction of the circular muscle, which finally leads to the narrowing of the pupil. The diameter of the pupil becomes smaller, which leads to the decreasing of dark vision. Another effect, which is related to previous one, is decreasing of intraocular pressure. This also results from the contraction of the circular muscle of the iris, which triggers opening of so-called Schlemm's channel, which increases outflow of the liquor from the anterior chamber of the eye. And this effect, decreasing of intraocular pressure, is widely utilized in treatment of such disorder as glaucoma, which is actually increased intraocular pressure. Also, M-cholinergic receptors are found in the ciliary muscle of the eye. This muscle is responsible for the accommodation. Contraction of ciliary muscle, which is observed under stimulation of M-cholinergic receptor, leads to the relaxation of Zins's ligaments, increasing the curvature of lens, and in this condition our eye sets for the near point of vision. This condition is called spasm of accommodation. M2 subtype of muscarinic receptors are widely distributed in our myocardium, cardiac muscle cells, where the stimulation of these receptors decreases all functions of our heart, such as decreased automatism, excitability, conductivity, and contractility. M3 cholinergic receptors are found in the smooth muscle cells of different inner organs, and their stimulation increases, for example, tonicity and peristalsis in GI tract, in respiratory system, bronchi, in biliary and urinary tracts. And also at the same time tonicity of sphincters is decreased. M3 receptors increase, stimulation of M3 receptors also increases secretion of exocrine glands, such as gastrointestinal glands in the stomach, in the intestine, bronchial glands, salivary glands, and so on. Also, stimulation of these receptors increases secretion of sweat glands, which are actually innervated by sympathetic nerves, but which have M cholinergic receptors on the surface of these cells. Next, we will talk about the localization and effects of the nicotinic receptors. These receptors, or N cholinergic receptors, are also found in different brain regions, such as in the brain cortex, in neurohypophysis, in substantia nigra and striopalliidal system, where they perform a variety of different functions, which we will discuss later when we start talking about the pharmacology of CNS. Also, N receptors are widely found in ganglions, both of parasympathetic and sympathetic nervous systems. In these ganglions, stimulation of N cholinergic receptors increases the influences of sympathetic and parasympathetic branches on effector organs. Next localization of N receptors is medullary substance of adrenal glands, where they regulate secretion of adrenaline into the bloodstream. Synocarotid zone or carotid glomeruli also are rich in N cholinergic receptors, where the stimulation of these receptors leads to the reflex activation of breathing center in the brain medulla. And the last, but one of the most important localization of N receptors is neuromuscular junctions of skeletal and diaphragmatic muscles. And stimulation of N cholinergic receptors by acetylcholine there triggers the contraction of these muscles. So let's move to the pharmacology of the drugs that affect cholinergic innervation. Before we start to talk about the classification and pharmacodynamics of these agents, few words about these two substances, acetylcholine and carbocholine, which belong to the group of direct M and N cholinomimetics. Acetylcholine is the natural neurotransmitter of parasympathetic nervous system, and the principal characteristic of this substance is that it is quite quickly destroyed, decomposed by acetylcholinesterase enzyme, and the duration of action of the substance is only up to 15 minutes after subcutaneous injection. Carbocholine acts a little bit longer, but also the duration does not exceed 1 hour. That's why these two substances are used only in experimental medicine, only for some kind of medical research, because of their short duration of action. And if you need clinically relevant cholinomimetic effect, you have to use other groups of substances, other group of drugs that are called cholinesterase inhibitors. So, classification of cholinergic agents. We have two groups of drugs, which are called cholinomimetics or cholinergic agonists, and anticholinergic drugs or cholinergic antagonists or cholinergic blockers. The first group of drugs, cholinomimetics, these agents excite directly or lead to excitation indirectly of different types of cholinergic receptors. And according to the type of the receptor which is involved in this process, we classify cholinomimetics into the following groups. M plus N cholinomimetics, which stimulate both muscarinic and nicotinic cholinereceptors. And they can be with direct action and with indirect action. Or another name for this class is cholinesterase inhibitors. The principal difference between them is the following. Drugs with direct action, they bind directly to the cholinergic receptors and lead to their excitation. So these are the drugs which mimic the action of natural neurotransmitter acetylcholine. Drugs with indirect action, they do not bind with cholinergic receptors, but they lead to the accumulation of acetylcholine in the synaptic cleft, which further binds to these cholinergic receptors and produces their stimulation. The second class of cholinomimetics is M cholinomimetics. These are the drugs which stimulate only muscarinic cholinergic receptors. And the third class of cholinomimetics is N cholinomimetics, which is clear from its name, stimulate only nicotine-sensitive cholinergic receptors. The second class of cholinergic drugs are called anticholinergic agents, or cholinoblockers, or cholinergic antagonists. They are also classified depending on the type of the receptor which is involved in the process, into M cholinoblockers and N cholinoblockers. Nicotinic cholinoblockers are further divided into ganglion blockers, which block N cholinergic receptors or neuronal type of N receptors, and peripheral myorelaxation drugs, which block muscular type of N receptors or NM receptors. Also, we have specific class of central cholinolytics, which mainly block the cholinereceptors that are located in the CNS. The first class of cholinergic drugs which we will talk about is indirect acting M plus N cholinomimetics, or cholinesterase inhibitors. These drugs can be classified into different types, into different classes. For example, by reversibility of cholinesterase inhibition into the drugs with reversible and irreversible action. Drugs with reversible action includes the following: prozerine, pyridostigmine, oxazil, distigmine, galantamine, physostigmine, and edrophonium. The principal characteristic of these agents is that we have pharmacological effect of these drugs only when they are present in the human body. After the elimination of these agents from the human body, their action, cholinesterase inhibition, stops. The second type is the drug with irreversible action. Mainly they are used in clinical practice only for treatment of severe cases of glaucoma and are represented with such agents as fosfacol and armin. It should be noted that some substances, for example, agricultural pesticides such as dichlophos and war gases such as zarin and zoman, by their mechanism of action are also cholinesterase inhibitors with irreversible action too. This is important in choosing the appropriate treatment of the intoxication by these substances. Also, cholinesterase inhibitors can be classified by their chemical structure into two classes, which are quaternary ammonium compounds and tertiary amines. The first class, they do not pass through the blood-brain barrier. That's why they do not produce central effects, pharmacological effects on the central nervous system. Tertiary amines, they are more lipophilic compounds that can pass through the blood-brain barrier and produce central effects. As you remember, acetylcholinesterase is the enzyme that specifically cleaves acetylcholine to acetate and choline and thus terminates its action. This enzyme is located both pre- and postsynaptically in the nerve terminal where it is membrane bound. Inhibitors of acetylcholinesterase or indirect acting MN cholinomimetics indirectly provide cholinergic action by preventing the degradation of acetylcholine. This results in the accumulation of acetylcholine in the synaptic cleft and prolongation of its interaction with different types of cholinergic receptors. Therefore, these drugs can provoke a response at all cholinereceptors, including both muscarinic and nicotinic receptors of the autonomic nervous system, as well as at the neuromuscular junctions and in the brain. And if we are talking about the pharmacodynamics or pharmacological effects of this group of drugs, you have to remember that these effects are almost the same as those which are observed after normal stimulation of parasympathetic branch of autonomic nervous system. And they include the following. The first group of the effects are those which depend on the excitation of muscarinic receptors. In the CNS, these drugs, only those which can pass through the blood-brain barrier, can produce increased capacity for mental work, decreased sleepiness, emotional excitation, and increase of cholinergic influences upon inner organs. In the eye, as a result of contraction of the circular muscle of the iris, we can observe contraction of the pupil, decreased dark vision, and decreased intraocular pressure, which is extremely important because this effect is widely utilized in treatment of glaucoma. As a result of the contraction of ciliary muscle of the eye, we can observe relaxation of Zins's ligaments and spasm of accommodation. In our heart, stimulation of M-cholinergic receptors after administration of cholinesterase inhibitors decreases all cardiac functions, automatism, which leads to the decreased heart rate, excitability, conductivity, and contractility. And this is the reason why we use these drugs for treatment of different types of tachyarrhythmias. In smooth muscles of blood vessels, we can also stimulate M-cholinergic receptors, but vasodilation in this case is quite slight or moderate, and this effect is not used in clinical practice because mainly adrenergic drugs are much more effective in the regulation of blood pressure in cardiovascular system. In the smooth muscle cells of inner organs, this group of drugs can produce increased tonicity and peristalsis of smooth muscles in gastrointestinal system, in bronchi, in biliary and urinary tracts. And at the same time, tonicity of sphincters is decreased. That's why we use cholinesterase inhibitors for treatment of different types of atony of intestine or urinary bladder, for example. In the exocrine glands, cholinesterase inhibitors produce increased secretion in all types of these glands, including salivary glands, stomach glands, intestinal glands, bronchial glands, and so on. That's why in some cases we can use this group of drugs in treatment of xerostomia. This is insufficiency of salivary glands. Increased secretion of sweat glands is also observed after administration of cholinesterase inhibitors. That's why in very rare cases we can use these agents for treatment of renal insufficiency, because strong sweating is used in this case as extrarenal way of excretion of different types of toxins. And cholinergic receptors, nicotine-sensitive receptors. They are located in skeletal and diaphragmatic muscles, and activation of these receptors by cholinesterase inhibitors leads to the stimulation of neuromuscular neurotransmission. That's why we use this group of drugs for treatment of myasthenia gravis. This is genetic insufficiency of neuromuscular neurotransmission, which is treated by several types of indirect acting MN cholinomimetics. Medullary substance of adrenal glands, stimulation of N cholinergic receptors increases secretion of epinephrine, which leads to the increased stimulation of cardiovascular system. The heart rate and vascular tonus are increased, and these effects are partly masked by direct M cholinomimetic effect. In sinocarotid zone, we can observe reflex stimulation of breathing center, but this effect has no any clinical significance, as well as in the ganglions, where we can observe increased transmission of impulses from preganglionic to postganglionic fibers. Irreversible cholinesterase inhibitors, mostly organophosphate compounds, are commonly used as agricultural insecticides, which has led to numerous cases of accidental poisonings with these agents. Toxicity with these agents is manifested as nicotinic and muscarinic signs and symptoms, so-called cholinergic crisis. Depending on the agent, these effects can be peripheral or can affect the whole body. And typical symptoms of such poisoning, such intoxications, may include the following. General symptoms such as loss of consciousness and strong smell of poison. Symptoms which depend on the excitation of muscarinic receptors, such as meiosis or contraction of pupils, change in the blood pressure and heart rate, bronchospasm, indomitable vomiting and diarrhea, strong sweating. And effects which depend on the excitation of N cholinereceptors include mostly fibrillar contractions of skeletal muscles. And treatment of such intoxications should include the following measures. General detoxification, prevention of the absorption of the poison from gastrointestinal tract, and administration of different intravenous solutions with desintoxication properties. Usage of specific antidotes, which includes two the most important classes of drugs, which are M cholinergic blockers, mainly atropine sulfate, and cholinesterase regenerators. These are the substances such as dipiroxime, isonitrozine, alloxime, pralidoxime, and so on. These agents can reactivate inhibited cholinesterase and restore the normal process of degradation of acetylcholine in the synaptic cleft. And different symptomatic drugs are used for treatment of convulsions, for restoring of cardiac functions, treatment of bronchospasm, which are observed in case of intoxication by cholinesterase inhibitors. Another class of cholinergic drugs is called direct-acting M cholinomimetics. This class includes mainly two substances, two agents, which are called pilocarpine and aceclidine. These compounds are more toxic as compared to cholinesterase inhibitors. That's why they are mainly used locally in the form of eye drops for treatment of increased intraocular pressure or glaucoma. Next group of drugs which we will talk about is called M cholinoblockers or muscarinic antagonists. These drugs, they block muscarinic receptors in different parts of our body. And among the pharmacological effects, several should be noted. but all of them are extremely opposite to the effects which are observed after stimulation of parasympathetic branch of autonomic nervous system. So, among the effects of these drugs on CNS, we have decreased capacity for mental work, decreased CNS activity, decreased emotional excitability, impaired control of movement coordination, decreased cholinergic influences on the inner organs, and so on. In more details, we will discuss these effects, their mechanism and clinical relevance when we start discussion of pharmacology of central nervous system. Effects of M-cholinoblockers in the eye. Due to the relaxation of the circular muscle of the iris, we may observe dilation of the pupil or mydriasis. This effect is used for the examination of eye fundus and in some cases for the prevention of adhesion between iris and the lens in different inflammatory disorders of the eye. At the same time, relaxation of the circular muscle of the iris leads to the accumulation of the aqueous humor in the anterior chamber of the eye due to the closure of Schlemm's channel. And this leads to the increasing of intraocular pressure. And this effect is considered as the negative or side effect that is observed after administration of M-cholinoblockers. That's why this group of drugs is contraindicated for the patients with glaucoma. Also, M-cholinoblockers produce a relaxation of ciliary muscle of the eye. This leads to tightening of Zins's ligaments and decreasing the curvature of our lens. In this condition, our eye sets for distant point of vision, and this situation is called paralysis of accommodation. In clinical practice, it is used for the selection of eyeglasses and for the treatment of spasm of accommodation. In our heart, M-cholinoblockers block M2 cholinergic receptors, which decreases parasympathetic influences on the heart, which finally results into the increased cardiac functions, automatism, excitability, and conductivity. That's why we use this group of drugs for treatment of cardiac blockades, such as atrioventricular blockade. In the smooth muscles of blood vessels, in skeletal muscles or in pelvic organs, we may observe vasoconstriction and increased blood pressure. But as you remember, this effect is not utilized in clinic because sympathetic agents are much more effective in regulation of blood pressure. In smooth muscles of inner organs, M-cholinoblockers decrease tonicity and peristalsis in GI tract, in bronchi, urinary tract, and so on. And tonicity of sphincters at the same time is increased. That's why we use this group of drugs as the agents which remove spasms or spasmolytic agents for the treatment of intestinal, urinary, biliary, and other types of colics. Also, M-cholinoblockers in some cases are used for treatment of bronchial asthma and chronic obstructive pulmonary disease. In these conditions, the advantage of M-cholinoblockers in comparison with other classes of broncholytics is that they also inhibit secretion of bronchial glands. Also, these drugs decrease uterus cervix tone during the labor. But such effects on smooth muscle cells also ensures the side effect, the negative effect, which are constipations. In our exocrine glands, M-cholinoblockers decrease activity of these cells in these glands, which is the basis of the administration of M blockers in treatment of hyperacidic gastritis, gastric and duodenal ulcer, pancreatitis, and for the decreasing of salivation during stomatological manipulations, for premedication, and, as I mentioned before, in treatment of bronchial asthma. M-cholinoblockers can be classified according to several different principles. First, by chemical structure and origin into two major classes, which are tertiary amines. Usually these are different alkaloids from medicinal herbs, such as atropine, scopolamine, hyoscyamine, platyphyllene, and so on. And the second class, synthetic agents, which are usually quaternary ammonium compounds, such as methoxin, ipratropium bromide, pyrazipine, tropicamide, homatropine, and so on. The difference between them is that tertiary amines are more lipophilic and they can pass through the blood-brain barrier and produce central effect, as opposed to quaternary ammonium compounds, which produce only peripheral pharmacological effects. By selectivity, M blockers are divided into non-selective, which are represented with central M blockers, which produce mainly their pharmacological effects in the brain, peripheral M cholinoblockers with resorptive action, such as atropine and platyphyllene, which produce the effects outside of the CNS. Peripheral M cholinoblockers with local action, which are used for treatment of respiratory disorders, such as ipratropium bromide and tiotropium bromide. These agents are produced in form of inhalations for treatment of bronchial asthma and chronic obstructive pulmonary disease. And peripheral M cholinoblockers with local action that are used as eye drops for different ophthalmological disorders. And we have selective M cholinoblockers, which mainly block M1 cholinereceptors in gastric parietal cells, such drug as pyrazipine, which is mainly used for treatment of hyperacidic gastritis and gastric ulcer. When we are talking about M cholinoblockers, we have to remember that these drugs can also be overdosed, or we may have the situation of poisoning by M cholinoblockers or another alkaloids with M cholineblocking activity from different medicinal herbs. And such symptoms of poisoning or intoxication or overdose include the following: psychomotor excitement, delirium, and hallucinations due to the central effects of these drugs, significant dilation of pupils, mydriasis, tachycardia, dryness and hyperemia of the skin, increased body temperature, dryness of the mouth, impairment of swallowing, and hoarse voice. And treatment of this intoxication usually consists of general detoxification measures, such as prevention of absorption of the poison in the stomach and administration of desintoxication solutions. Administration of specific antidotes, and in this case, antidote for M cholinoblockers is cholinesterase inhibitor, such as neostigmine or physostigmine. In this situation, inhibition of enzyme acetylcholinesterase leads to the prevention of neurotransmitter degradation in the synaptic cleft, accumulation of acetylcholine, and this increases interaction of acetylcholine with M cholinergic receptors, and neurotransmitter displaces M cholinoblocker from the binding with the cholinergic receptors. Also, we use different symptomatic agents to treat specific symptoms that are observed during the poisoning, such as elimination of psychomotor excitement, normalization of cardiac rhythm, and so on. The second class of cholinoblockers is called nicotinic cholinoblockers, or blockers of N-cholinereceptors. Depending on the type of cholinergic receptor that is affected by the drug, we classify these agents into ganglionic blockers that block neuronal type of nicotinic receptors in vegetative ganglions, both sympathetic and parasympathetic, and peripheral myorelaxation agents, which block muscular type of nicotinic receptors that are located in neuromuscular junctions, and by this way, this drug impair neuromuscular neurotransmission. The examples of ganglion blockers include benzogexonium, gigronium, pachycarpine, and some other drugs. Peripheral myorelaxation drugs are represented with tubocurarine, pancuronium, atracurium, vecuronium, rocuronium, and some other drugs. Ganglionic blockers specifically act on the nicotinic receptors of autonomic ganglia. These drugs show no selectivity toward the parasympathetic or sympathetic ganglia and are not effective as neuromuscular antagonists. Thus, these drugs block the entire output of the autonomic nervous system at the nicotinic receptor. The responses of the ganglionic blockers are quite complex and mostly unpredictable. That's why nowadays this group of drugs is rarely used therapeutically, but often serves as the tool in experimental pharmacology. Myorelaxation drugs or neuromuscular blockers are the second type of cholinoblockers, and these drugs block cholinergic transmission between motor nerve endings and the nicotinic receptors of skeletal muscles. They possess some chemical similarities to acetylcholine molecule and act either as antagonists, so-called non-depolarizing drugs, or as agonists, so-called depolarizing drugs, at the receptors on the end plate of the neuromuscular junctions. The mechanism of action of these drugs is associated with impairment of the normal process of depolarization and repolarization of the cell membrane of skeletal muscle cell. Normally, when acetylcholine binds to the N-cholinergic receptor, it leads to the opening of sodium channel. Sodium enters the cell, produces depolarization and excitation of the effector cell, and muscle cell contracts. After that, acetylcholine is removed from the binding with the receptor, sodium channel closes, and repolarization of such membrane develops, which restores normal membrane potential. We have two types of neuromuscular blockers, which are called non-depolarizing and depolarizing, which are slightly different in their mechanisms of action. So, non-depolarizing drugs, they block acetylcholine at the nicotinic receptors, and they compete with this molecule at receptor without stimulating the receptor. And by this way, they prevent depolarization of the muscle cell membrane and inhibit muscular contraction. Their competitive action on the nicotinic receptors can be overcome by administration of cholinesterase inhibitors, such as neostigmine, which increase the concentration of acetylcholine in the neuromuscular junctions. And clinicians employ this strategy to shorten the duration of neuromuscular blockade. Depolarizing agents work by depolarizing the plasma membrane of the muscle, similar to the action of acetylcholine. However, these agents are more resistant to degradation by acetylcholinesterase and can more persistently depolarize the muscle fibers. Succinylcholine is the only depolarizing muscle relaxant which is used in clinical practice. This drug attaches to the nicotinic receptor and acts like acetylcholine to depolarize the neuromuscular junction. But unlike acetylcholine, which is instantly destroyed by enzyme acetylcholinesterase, the depolarizing agent persists at high concentrations in the synaptic cleft, remaining attached to the receptor for longer time and providing sustained depolarization of the muscle cell. The depolarizing agent first causes opening of the sodium channel associated with nicotinic receptors, which results in depolarization of the membrane, so-called phase 1. This leads to the transient twitching of the muscle fasciculations. Continued binding of the depolarizing agent renders the receptor incapable of transmitting further impulses. And with time, continuous depolarization gives way to gradual repolarization as the sodium channel closes or is blocked. And this causes a resistance to depolarization, so-called phase 2, and as a result, flaccid paralysis of the skeletal muscle. Different muscles have different sensitivity to the action of neuromuscular blockers. So when we administer these drugs, the most sensitive are facial muscles. They relax first. Then the muscles of the neck and larynx, muscles of extremities, and muscles of the trunk are relaxed. And the most resistant to the action of these drugs are muscles of our diaphragm. And actually the range between the doses when myorelaxation begins with facial muscles to the dose when diaphragm is completely relaxed is called as wideness of myoparalytic action. And you have to remember that after relaxation of diaphragmatic muscles, the patient cannot breathe independently. That's why he or she should be intubated and joined to the artificial ventilation device. So, as we mentioned before, these agents are classified into depolarizing and non-depolarizing. Non-depolarizing drugs are further classified according to their pharmacokinetic properties, and depending on the duration of action, we have short, intermediate, and long-acting drugs. Depolarizing drugs actually are represented with one agent, which is succinylcholine or succinylcholine, or another name is ditylene, which is widely used during short surgical manipulations. Neuromuscular blockers are clinically useful to facilitate rapid intubation when needed due to respiratory failure, for example. During surgery, they are used to facilitate endotracheal intubation and provide complete muscle relaxation at lower anesthetic doses. Also, they are used in reposition of bone fragments and dislocation of joints. Rare indications include urgent treatment of convulsions in tetanus, electroconvulsant therapy, and poisoning by strychnine. Typical side effects may include change in the cardiovascular function, such as hypo or hypertension, tachycardia, and so on. If the patient is overdosed by neuromuscular blockers, the appropriate treatment of this condition differs according to the type of the agent that was used. For non-depolarizing drugs, as I told before, we use cholinesterase inhibitors, which lead to accumulation of acetylcholine and competitive antagonism with neuromuscular blocker. But for depolarizing drugs, this approach is not suitable, in this case we have performed blood transfusion, which contains the cholinesterase that can destroy the drug which produces muscle relaxation. And with that, I wanna thank you for watching, and I hope you enjoyed this video about drugs that affect cholinergic neurotransmission in our body.